ST segment elevation. That is the topic today, medics. How many times have you gone on a call, you saw ST segment elevation, and you're like, why aren't they having a STEMI? Why isn't my life pack saying they're not having a STEMI? So we are going to go over some of the differentials of ST segment elevation so we can kind of close the gap between ER physician and medic, and that's pretty much the point of us further learning so we can become better clinicians when we're on scene and we're reading these 12 leads. Now, I know some of you are saying, well, if I have ST segment elevation, I have to call a STEMI no matter what, so what does it matter? Technically, you might be right. But this podcast is geared more towards the medic who wants to learn more so he can be a better patient advocate, so he can be a better, or she can be a better clinician on scene. This podcast is not for the medics who don't care. They just want to go through the steps. That's fine. But for those of you who want to learn some more, let's do it. ST segment elevation. Well, there's many different causes of ST segment elevation. The best mnemonic that I could find or think of, which I didn't think of, I found it, is elevation itself. And we're going to start with E for electrolytes, and that's when we're mainly talking about our potassium hyperkalemia. L, left bundle branch block. Early repos, our second E. Ventricular hypertrophy. We have A for aneurysm. T is for treatment, and we're talking mainly about pericardiocentesis. Infection and injury, which is our pericarditis and our MI. Osborn waves for our hypothermic patients, possibly hypercalcemic patients, and non-occlusive vasospasm. But we got to throw in a B because we got to give BRUGADA syndrome some love. That's what we're going to go over today. We're not going to go too much into the treatment aspect of it, pericardiocentesis. All we're going to say about that is if you're doing a pericardiocentesis and notice ST segment elevation, it might be normal. We're not going to talk too much about non-occlusive vasospasm. That is our angina patients. If you see chest pain, ST segment elevation, well, that's going to kind of go hand in hand with our infarction. So getting on to it. Hyperkalemia. Now, what are the classic EKG changes of hyperkalemia? Well, the books are always going to say you got the classic 5, always in that order, as opposed to, according to the book. We get the tall peaked T waves, we get prolongation of our PR interval, then we get our absent P waves, then we get a wide QRS turning into a sinusoidal pattern or eventually VFib. All right? But patients don't always follow the book, and there is no evidence that correlates potassium levels to any one of these EKG changes. So if you see any of this, we have to be able to recognize that there might be some type of electrolyte problem. So here's a pattern of our classic hyper-K, right? Almost normal. Got a little bit widening of our T wave here. Losing our P wave, we get that peaked T wave here. Then we have a losing of our P wave, QRS widening, turning into a sinusoidal pattern. That is what tests love. That's what you have to learn for your exam, but keep in mind your patient might not present that way. So here's a 12 lead of a patient with hyper-K. What am I looking at? Well, the thing that stands out to me the most are these tall peaked T waves. Now, you have to imagine that this T wave here, if you were to sit on that, it would hurt, right? Pointy. And they also call this the Eiffel Tower complex, right? We got a pointy T wave and a very narrow base. Also looking at this T wave, we're noticing another thing. We also notice that we have a slurring up here of our ST. It's not flat, it's not straight across. And my T waves are symmetrical, meaning my upstroke and my downslope are symmetrical to each other. Symmetrical upstroke, downslope, pointy, very pointy T waves, peaked T waves as they're called, are very classic for hyperkalemia. Also, look at the size of this T wave in relation to my downward QRS complex. It's almost the same size, yet it's very big even for early repolarization or hyperacute T waves, which we're going to talk about later. But this is a very big T wave in relation to my downward deflecting QRS complex. So that is a hyperkalemic T wave. Let's look at another one. All right, what do I got? I got a symmetrical T wave peaked. Here you can see it really good in V4. Symmetrical T wave and peaked. All right. That is another classic hyperkalemic T wave. All right. So if we're seeing some ST segment elevation associated with T waves that look like this, it might not be a STEMI. This might be hyperkalemia. So what am I looking for my hyperkalemic T's? They are peaked in the leads with the elevation. And remember, ouch. These T waves are going to look like they're going to hurt if you sit on them. They are symmetrical up and down strokes. Your QRS complex will sometimes be wide, usually greater than 120 milliseconds, and we might see some ST depression in other leads. That could be normal. All right, so that is our hyperkalemia. Well, left bundle branch block. That is the L of our mnemonic. The bane of every paramedic's existence. A patient with left bundle branch block. We don't have old EKGs to compare. We don't know if this is old or new, so we have to presume that it's new unless the patient is absolutely astute on their diagnosis. So they might be able to tell you they have a left bundle branch block, but unless you can see an old EKG or the patient has their history written down, you have to presume it's new, and then gotta call a STEMI. But is there a way to look at a left bundle branch block and kind of tell whether or not the ST segment is normal or abnormal? Well, there sort of is, and that's what we're going to talk about today. All right. So what is normal for a left bundle branch block? Well, they're usually going to be wide. You're going to have some ST segment elevation. All right. But what we're looking for is what they call discordance. And more importantly than that, we're looking for appropriate discordance. So what does that mean? Well, excuse me. Discordance is when your ST segment is going in the opposite direction of your prominent QRS complex. That is discordance. Concordance would be when your QRS complex is going in the same direction of your QRS complex. In a normal left bundle branch block, discordance is normal, but appropriate discordance is normal, meaning that for discordance to be appropriate, it would have to be less than 5 millimeters, which the sensitivity of that isn't exactly high, or it's around the 20%, as I've read. So in those situations, we might have to look at voltage criteria, and we'll talk about that in a minute. So all that in mind, we're thinking about SGARBOSSA criteria. So what is SGARBOSSA criteria? Well, let's talk about that. SGARBOSSA. ST segment elevation greater or equal to 1 millimeter concordant. That means in the same direction as a predominantly positive QRS complex in at least one lead. That's worth 5 points. Anything greater than 3 points on SGARBOSSA criteria equals STEMI. All right. We have ST depression greater or equal to 1 millimeter in leads V1, V2, or V3. That's worth 3. And then we have our ST segment elevation greater than 5 millimeters. That is discordant in the opposite direction of. That is the too much of a good thing. But because the sensitivity is so low, SGARBOSSA only gives that 1 point. You might have to look for voltage criteria, and we'll talk about that. So what is discordance? Well, thanks to EMS12lead.com, which if you have not checked out that site, you have to. The site is awesome. EMS12lead.com. I stole this picture, and in this one we have an upward QRS complex with a negative T wave with some J point depression. This is discordance. That's normal. Look at B here. We have a downward deflecting QRS complex. We have an elevated J point, less than 5 millimeters. It is discordant ST segment elevation in relation to the QRS complex. That is discordance. That is normal. That's what you want to see on a left bundle branch block. Let's talk about concordance. Well, look at this. We have an upward deflecting QRS complex with an upward elevated J point and a T wave that's going up. That is concordant. That is bad. We don't want to see that. Well, here we see a downward deflecting QRS complex with largely, is that a word? Largely? Well, this is largely elevated, greater than 5 millimeters. This is that too much of a good thing. We have discordance, but it's inappropriately discordant because it's greater than 5 millimeters. Remember, sensitivity of this is about 20%. So we're looking at this ST segment in relation to the size of my R wave. This is about half the size of my R wave, so that would be grossly out of proportion. We want a smaller ST segment in relation to my R wave. All right. Well, let's look at my QRS complex here. This is a downward deflecting QRS complex with J point depression. All right. If this is in V1, V2, or V3, SGARBOSSA criteria states that this is bad. All right. This would be injury. This would be a patient who needs to go to cath. This is a STEMI. This is a STEMI in the presence of a left bundle branch block. And not only does SGARBOSSA's criteria work for left bundle branch block, let me back up. It works for paced rhythms as well. So all of you medics out there who say that, oh, why am I doing a 12 lead on my patient? I'm just going to see a paced rhythm. Well, you're wrong. All right. We can tell, or it would aid us to see if we can tell discordance from concordance. Well, let's look at some examples here. Here's an EKG we've probably all seen before. We have our Y complex, our notching in V5 and V6. We have ST segment elevation, so we would say that this is normal because of my patient's left bundle. I don't have a millisecond reading on this EKG, but I have deep R waves, little ST segment elevation in relation to the size of my R wave. It's discordant. That is normal. This is normal for a left bundle branch block. All right. What about this? Is that bad or good? Well, looking right off the bat, what do we have? We have wide complexes. If you look at this EKG close enough, you can see the notching there in your QRS complex there. This is a left bundle, but here I have inappropriate concordance. All right. I have inappropriate concordance. Here I have concordance, right there. It's going in the same direction as my QRS complex. Here I have inappropriate discordance. Here, you can really see it there. All right. This patient has had a left bundle branch block with an MI. All right. So that's a classic picture of it. Looking for that concordance. So, WTF. What is going on here? Well, I'm looking here, and I have a bundle branch block pattern, V5, V6. I can call this a left bundle. But what's going on here? Well, here we can see two aspects of SGARBOSSA's criteria. We have a downward deflecting R wave, and we have a negatively depressed J point. All right, I have a concordant J point. I have concordant ST depression greater than 1 millimeter. That is SGARBOSSA's criteria. But I also have elevation in 2, 3, and AVF. So this guy might be having some inferior wall involvement too. This is a STEMI. This is discordant ST elevation, but it's inappropriate because it's greater than 5 millimeters. And voltage criteria in relation to my R wave here in 3 is massive. So this is a great example of why you always want to do 12 leads on your left bundle branch blocks and your paced rhythms. All right. So moving on to our next E, we have early repolarization. So what are we looking for? Well, we're looking for a notched J point, usually in V3, and we're going to see some examples of that. You can kind of point it out with some practice. We're looking for that classic concave upward ST segment, right? When you're studying EKGs, you're studying ST segments, you're going to come across two words: concave upward, convex downward. All right, concave up is good, convex down is bad, and we're going to do some examples of that. Usually the ST segment elevation is going to be in your V2 to V5 leads, and you might see some PR depression, usually less than 2 millimeters of elevation, blah blah blah. Not as peaked as hyperkalemic T's. They are more rounded. All right. So enough of the talk. Let's look at some pictures. All right. Let's look at A versus B here. Well, here's my J point, but I have a downward sloping ST segment here. Almost looks like it's smiling at you, right? So we call that concave. And you'll hear that say concave downward. Then I look at B here, and this is not smiling at you. It's frowning at you, right? This ST segment is sad. So this would be bad. This is not an early repole ST segment. This is a hyperacute T wave due to MI. Yes. So good, bad. Concave downward, convex upward, right? We say, are they smiling? Right? We look at it. Well, here you can see a nice little notching of the J point there. That's what we're talking about with early repole. Classic. We also see some PR depression. That is classic for early repole. So if I got PR depression, notching of my J point, concave downward ST segment elevation, right there it's circled, like he's smiling at you, yay, your patient's not having an MI. This is probably due to some early repole. All right. Oh, now here's a comparison. Happy face, frown face. This ST segment is happy. This one is bad. This one is sad. All right. Happy, sad. Again, thank you, EMS 12 lead. Now, look at this. Remember we talked about hyper K T waves being symmetrical. Is that symmetrical? No. This one is a more gradual rising upstroke with a more drastic downslope. Gradual, fast. Look at V6. Gradual, fast. Let's look at V2. Gradual, fast. This is an asymmetrical T wave. And the T wave is more rounded. All right, it's more rounded at the top. That's not as peaked as a hyper K T wave. So we have a mixture of all of those little things would make me say that this is a early repole type T wave. Not hyperacute, not hyperkalemic. Little notching of my J point, concave downward ST segment. Upstroke is asymmetrical to downstroke, early repole. What do we see here? Notch, notch, notch. We got a little notch there. If you look at it closely, we have a notching of the J point. Concave downward. Straight down, downstroke. Not as peaked, not as big as hyperkalemic T wave. So this is, again, an early repole T wave. Yay! Going on to ventricular hypertrophy. Now, this is not a 12-lead lecture per se, so we're not going to go into all the criteria for ventricular hypertrophy, but what are some things to look for, right? There's lots of different scoring methods for ventricular hypertrophy, but the most commonly used is the Sokolov-Lyon criteria, which pretty basically says you look at the S wave depth in V1 and you add it to the tallest R wave in 5 or 6, and if you get 35 millimeters or greater, it is ventricular hypertrophy. So looking at your S in V1, in your R in V5 or 6, or we can say looking at your S wave in your right precordial leads, or an R wave in your left precordial leads, if they add up to 35 millimeters or greater, then you have ventricular hypertrophy, and ST segment elevation or depression might be in your differential. So ST segment depression and T wave inversion on the left side of leads is going to show you your strain patterns. So let's look at that, right? And your ventricular hypertrophic patients might be left axis deviated. Now let's look at that. Right versus left side leads. All right. Well, here, this is showing your strain pattern. All right. You don't see a strain pattern here, but if you were to add that R wave up to this R wave, you would find out it's greater than 35 millimeters, and thus you would have ventricular hypertrophy. But ventricular hypertrophy in the presence of ST segment depression, T wave inversion in your left precordial leads equals strain pattern. So add it S, add it R, greater than 35 millimeters, ST depression equals strain pattern. All right. So in the left ventricular hypertrophic patients, we have to look at the entire EKG, right? Looking at my limb leads here, I can tell axis deviation. I have up, up, down, but because that's down, I look at AVF. Is it predominantly negative? Yes, this is left axis deviation. Look at my R wave in V1. That's long, I count it. Look at my R wave, I count it. It is greater than 35 millimeters. I have some ST depression with T wave inversion. This is left ventricular hypertrophy with a strain pattern along with my left axis deviation. Cool stuff, huh? Let's do it again. Take 2. Well, I have up, down, down. That's quite obvious that this is left axis deviation in my bipolar leads. I'm looking at an R wave in V1 or 2, adding it to an R wave in V5 or V6 equals 35 millimeters or greater. I have ST segment depression and T wave inversion. This is a strain pattern associated with left ventricular hypertrophy. But here's some ST segment elevation. Now remember what we learned so far. Is this concordant or discordant? Well, this would be discordant. It's discordant, and it's appropriately discordant. I also have some concave downward, uneven, asymmetrical T waves here. Those are not infarction T waves. All right? That is normal for your left ventricular hypertrophy, possibly some early repole going on. We don't know. We don't have echoes. We don't have an electrophysiologist at bedside. So that's what we have to go with. Pretty cool stuff, huh? So going on to the A of elevation is our aneurysm. Aneurysms in bold, capital, extremely difficult to pick out. All right, it's going to be kind of hard for us to diagnose this in the EMS setting. Like I said, we don't have echo at bedside, but if you think the patient is having an old MI, then keep in your mind that they might be presenting with an aneurysm. All right, this is the old MI mistake. What we're going to do is look for a right bundle branch block with persistent ST segment elevation. All right, keep that in mind as we keep doing this. We're going to see deep Q waves in our aneurysm patterns, right? So let's go to the guru of EKGs, Dr. Smith. If you have not checked out Dr. Smith's EKG blog, you are missing out and doing yourself a disservice. He is the man when you're talking about EKGs. So you want to go deep sea diving? Well, let's talk about what Dr. Smith has to say. When we're looking for aneurysm, he says, look at the T to QRS ratio. All right, you're counting your T and you're counting your QRS. You're dividing the two and you're coming up with a ratio. A high T to QRS ratio indicates acute STEMI. A low one indicates left ventricular aneurysm. And as his study that he did, this is about 90% specific. So that is a big deal, all right? So to come up with this T to QRS ratio, you measure the amplitude of the T divided by the depth of the S, and you get a number, right? If it's higher than 36 or 0.36, then the STEMI is highly likely, right? If there's only one lead through V1 through V4 with a T to QRS ratio greater than 0.36, your STEMI is likely, all right? Or if the sum of the T waves in V1 through V4 divided by the sum of the S waves in the same leads is greater than 0.22, then STEMI is likely. Are we going to remember it? I have no idea. It all depends on how passionate you are about EKGs. But let's look at some examples, all right? So shake it off. Shake it off. Dr. Smith is the man. We only walk in his shadow. So let's look at what we're talking about here. Now looking at this in V1, this is not an S wave. This is a QS wave, right? Or you can just say this is a Q wave. This is a big, huge Q. So when we look at this, we're going to say that this is some ST segment elevation of only 1 millimeter. Then we have our QRS duration of 11. All right. We divide that, we get 0.09. It's not greater than 0.36. So if we see this deep QRS complex, this deep Q wave, wide in nature, some elevation, if we use Dr. Smith's equation, then this is going to tell us that this patient is probably having a ventricular aneurysm. And if we were to look at this at first glance, 9 out of 10 medics would say that this is probably an old MI. Let me rephrase that. 9 out of 10 medics, no. 6 out of 10 medics probably wouldn't even recognize that that is a deep Q wave. 9 out of 10 medics would probably say that this is an old MI. And until I started studying EKGs, I probably would have said the same thing. All right? So let's look at this. MI or LVH? Check it out. Well, we see discordance here, but this is V4. This is not concave downward. This is a convex upward elevation, so we can say that this is bad. We got wide complex, but if we count the T wave here, that's 5, and our QRS complex, which is 13, gives us 0.38. This is a STEMI. This is not ventricular aneurysm. And remember I said about SGARBOSSA criteria. Now, SGARBOSSA's criteria when it comes to ST segment elevation is accurate, except for that third rule when you're talking about excessive or inappropriate discordance being greater than 5 millimeters, how it has a sensitivity of about 20%, give or take. Well, this is why, all right? You're looking at the ratio between your ST segment elevation and your S wave depression, or your downward sloping S wave. Looking at it here, we see that there is a high ratio of T to QRS greater than 0.36. This patient is having a STEMI. All right, so we're looking at voltage criteria mainly when we're looking at that third rule for SGARBOSSA criteria. What do you think is coming next? Whoa, what is going on here? All right, well, let's look at V1 and V2. I see a slight little notching. It's wide. Now this kind of looks just like that last picture we have. Deep Q wave, some ST segment elevation here. We have ST segment elevation here. All right. So this is diagnosing as an anterior wall MI, but we're looking at this. Deep Q waves, some ST segment elevation, that T to QRS ratio is very low. We're looking at about 0.09 to 0.10. Remember, that criteria only needs to be in one lead. This patient's probably having a ventricular aneurysm. All right. I show this EKG to everybody at my station, and they diagnose this as having an anterior wall MI. And this is scary stuff. All right. We're still going to be calling STEMIs on this patient, but they're going to end up having a ventricular aneurysm as well. All right. So cool stuff. Reading our EKGs is an art. All right. So as far as our treatment, like we said, not much to say here. Take a breather. It's not getting any easier. You're doing a pericardiocentesis on somebody, and they develop ST segment elevation. Might be normal. That is the T in our elevation mnemonic. All right. Going into infection, we're talking about pericarditis. All right. Now, pericarditis, we're looking for ST elevation in all leads except AVR, V1, and 3. In those leads, we might see some depression, AVR. Dr. Smith, yet again, 37 straight cases on his blog documents 37 straight cases of patients with pericarditis presented with ST depression in AVR, never in a STEMI. That's really cool stuff. Again, if you have not checked out his blog, do it. All right. You might see some PR depression, but with pericarditis, you will never see reciprocal changes. All right. Like I said, this is not a 12-lead course. We're not going to go too far into reciprocal changes, but if you see ST segment elevation present in all leads except for AVR, V1, and 3, some ST depression in AVR, no reciprocal changes, you're probably looking at pericarditis. If you see reciprocal changes, you have to start thinking of something else, all right? But with pericarditis, you have to look at the entire EKG to get a good picture of what's going on, all right? We have to rely on our patient interview and our assessment skills in figuring out what this is. Are they having sharp pain? Are they having dull pain? Is it radiating? Is it positional? That is also going to aid in us differentiating between pericarditis and STEMI. All right. Well, if you read about pericarditis, you'll say that pericarditis kind of evolves, right? Stadium 1 through 4, in which you have classic pericarditis here. We have PR depression, ST segment elevation that is smiling at you. Then our PR segment starts to go back to baseline. ST segment drops. Then we have a baseline PR segment, T wave inversion to a normal EKG. All right. So that is the evolving pericarditis. So this PR needs an SSRI because it is depressed. All right. This is deep PR depression, classic of pericarditis. We have concordant ST elevation, but it is concave upward, which could be good. So this would be a pericarditis type elevation with this PR depression. All right. Well, looky. What do we got? Looking at my whole EKG here, I see elevation. Not in 1. We're not looking at 3. Remember? But we have elevation in V2, in V3, in V4, V5, V6. I have global ST segment elevation. But look at AVR. I have ST segment depression. All right. Let's look at lead 3. I have no ST segment elevation in lead 3. This is classic for pericarditis, just like our rules said. All right. Massive ST segment elevation in V1 through 6. ST depression in AVR. No depression in or elevation in 3. This is pericarditis. Look smart next time you go to work. Well, let's look again. What do we got? Now looking at 1, elevation, slight elevation, 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 elevation. And all of this elevation is smiling at you. This is concave downward elevation, right? Looking at AVR, what do I see? I see ST depression, just like Dr. Smith said. The guy schmott. All right. So this is pericarditis, global ST segment elevation, and we see PR depression right there in lead 2. All right. Not paying attention to lead 3. We still don't see the criteria for elevation in lead 3, just like the rules say. This has everything on it. This is pericarditis. Nice stuff. So, going into injury, this is our bread and butter as paramedics, diagnosing heart attacks, right? Again, we're not going over 12 lead MI recognition. What we are going over, and the purpose of this podcast, is to go over the causes of ST segment elevation and how to guide us into distinguishing between them. All right. So, with ST segments, we're looking for that convex upward ST segment in 2 contiguous leads. We're looking for inappropriate concordant ST segs. That's the cool way to say segment, by the way. We're looking for hyperacute T waves. We are looking for, see if they're symmetrical. Are they rounded? Are they big in relation to the R wave? And are they wide? Remember, our hyper K T waves had the Eiffel Tower wave. They had a peaked top, narrow base. These hyperacute T waves are going to be wide in nature, right? And we're looking for reciprocal changes, which we would not see in pericarditis, right? So, reviewing, remember, happy, right? Happy's good. Notching J point, PR depression, high, happy ST segment, and remember sad. That's what we don't want to see, right? Thank you, EMS 12 lead. Again, happy, sad. Remember, SGARBOSSA criteria. Once again, we're going to hit it because it's important. Left bundle branch blocks or paced rhythms. We are looking for concordance, bad. Discordance, good, except for if it's inappropriate or my T to QRS ratio is out of whack. Bad. Here, bad. ST segment depression in greater than 1 millimeter. Bad. That is concordant. All right. So what do we got going on here? Well, I have symmetrical T waves here in V2. They're a little symmetrical, but the base of this is wide. All right. A lot wider than a hyper K T wave. I also have a little bit of elevation here in V1, but if I look at this, I also see what? 2, 3 in AVF. I have depression. These are reciprocal changes of this MI. All right, these are hyperacute T waves. With hyper K, I would not see ST depression. I would not see reciprocal changes in hyper K. I would see them in hyperacute T waves due to an infarction. So this is an anterior wall MI, reciprocal changes, but also look. I also have AVR elevation. I'm going to do a whole podcast on AVR because AVR is the bastard of all the leads. We really don't pay attention to him, but he is very important. So here's a good example of my hyperacute T waves. All right. So here's that last EKG's brother. What do we got? We see very big. Look at the size of this hyperacute T wave in relation to this R wave. That is too big. That is too big and wide to be a hyper K T wave. It's not pointy. It's rounded. with a very wide base. We don't want to see that. That is a hyperacute T wave. You can't look at that and say that that is a hyper K type T wave. But this is huge. We have no R wave progression. Rounded top, very wide base, huge T wave in relation to the R wave. This is a hyperacute T wave of a massive anterior wall MI. All right. Oh boy, what do we got? Well, let's see. Again, big, massive T waves. These are really wide. Look at the base of that sucker. That thing is huge, right? So that is a wide, rounded T wave. Big. It kind of swallows up that S wave there. But I also have some negative deflected T waves here in 3, but not too contiguous. I also have really deep T waves in AVR and some depression. So this is, again, hyperacute T waves of a massive septal anterior wall MI. All right. What's going on here? Well, this is a really bad day. We see ST segment elevation in 2, 3, and AVF. They got some inferior wall involvement going on. 2, 3, I'm sorry, V1, V2, V3, V4, V5, V6. This is massive ST segment elevation. All right. This is an inferior lateral wall MI. All right. I just kind of threw that one in there to give you guys a nice EKG to look at. All right. All right. We're closing it up almost. We're going on to O of elevation. We're looking at Osborn waves. All right. Osborn waves. Positive deflections occurring at the junction between the QRS and the ST segment. What does that mean? All right, you'll be able to see that here in a minute. Where we're going to see Osborn waves is your severe hypothermic patient or very severe hypercalcemia. You'll also see Osborn waves called J waves. All right, they usually have large notches, and they also call them humps. Well, let's look at this. See this? Our J point is kind of smashed up against my R wave here in V2. That is a classic Osborn wave, just like here. That is a classic Osborn wave here. And we can kind of make out a little U wave here too, right there in V5 and V6. That is classic for hypothermia. So we have an R wave, Osborn wave. This is a hypothermic patient from Dr. Smith's website whose core body temperature was around 32. All right. SHARON. Get it? Osborn waves. Anyway. Looking at V4 and V5, again, I have this smashing. Almost looks like my T wave is smashing into my R wave here. That is an Osborn wave. Osborn wave. We can see it all throughout the EKG. Osborn wave. Osborn wave. All right. So that could cause some ST segment elevation as your Osborn wave smashing up against that R wave. Right? But then again, we also might not see it too obvious. If we had a better view at this, you could see that there's a little notching of that J point smashing against that R wave. Not as pronounced as the last one, but I see no reciprocal changes here, ST segment throughout, no big hyperacute T's. And if I looked at that really closely, I would see the notch there. That is an Osborn wave. This is probably due to hypercalcemia. All right. And again, here's a better picture of it. Osborn wave slamming into this R wave here, developing my T right there, that J point, classic Osborn wave causing ST segment elevation. All right, not a STEMI, this is an Osborn wave. So non-occlusive vasospasm, which is the N of elevation. Like I said, we're thinking ischemia, we're resembling MI, and we are moving on, right, to the last aspect of ST segment elevation is BRUGADA syndrome. Right? Now, when we talk about BRUGADAs, we're talking about the sign. We're talking about the EKG sign. There's actually 3 different kinds of BRUGADA syndrome, but for all intents and purposes, we're going to be talking about one. We're talking about type 1. We're looking for a coved ST segment with elevation greater than 2 millimeters, usually in V1 through V3, followed by our negative T wave. It's the only ECG abnormality that we can find anyway useful, but this is BRUGADA's sign. All right. Another website you guys got to check out is Life in the Fast Lane, which is awesome if you want to learn about some more medicine. But If a patient has this on their EKG, they have Brugada sign. We can't say that they have Brugada syndrome because you need to do a diagnostic workup to say that they have Brugada's syndrome. Type 2 and type 3, just to put it in here, you're looking at a saddleback in V1 or V2, and a type 3 is combination thereof, but we're not going to be talking about type 2 or type 3. We're looking at type 1. So we're looking for Brugada sign in type 1. In order to say they have Brugada syndrome, they need to have one of these, right? Documented VFib, COVE type EKG in family members, nocturnal agonal respirations. But for our purposes, if we run on somebody who had a syncopal episode and we put them on an EKG and we see that in V1, we have our saddleback ST segment followed by a negatively depressed T wave. That is Brugada's sign, right? Brugada's is a bad channelopathy involving sodium channels at the my brain is shot. At the cellular level, it's a sodium channelopathy. Patients die from Brugada's, right? They will show EKG abnormalities with no wall disruption. This is a sodium problem in the channels. So if we see this in V1, this saddle-looking type of ST segment followed by a T wave depression, that is Brugada's sign. That is what's causing the ST segment elevation. Look at V1 and 2. This is another saddle sign. It's going down, slurps up, goes down again, negative T wave. You can really see it in V2 here. Goes up, comes back down, almost looks like a biphasic backward sine wave. That is Brugada's sign. All right? Keep that in mind. Here's a type 2 sign. Very hard to pick out in the field. We're not going to really distinguish between Brugada's or a type of ST segment elevation. What we would find this kind of weird is if you're looking at this and you're going, hey, does my patient have ST segment elevation in V2 but they don't have it in V1? I can't call it a septal wall MI because it's not two contiguous leads. Well, why is it not contiguous leads? It's probably Brugada sign due to the saddleback type ST segment elevation. All right? Again, a mixture thereof. We have ST segment elevation followed by negative T here in V1 plus a saddleback ST segment there. All right, so this is a combination of thereof. Type 3, very hard to pick out in the field. With practice, we could do it. Oh, that's it. ST segment elevation. Remember your mnemonic, right? E, electrolytes. L, left bundle branch block. The second E, early repole. V, ventricular hypertrophy. A, aneurysm. T, treatment. I, injury or infarction. O, Osborn waves. N, non-occlusive vasospasm. We gotta give Brugada some love. Elevation B. Hope you had a good time. See ya.